Hello, everyone. Thank you for coming. Welcome to NAHDO's 39th Annual Conference. We will be starting in about 1 minute. Before we begin, we want to cover a few housekeeping items. On your attendee screen, you can enter comments or questions in the chat. We hope you will take advantage of the opportunity to engage with our speakers and other attendees. This session is being recorded. We recognize and thank the California Healthcare Foundation for being our Petabyte sponsor. Information about all conference sponsors is available in the sponsor area of the platform. Please take a few minutes to visit each sponsor's booth, where you can find information about them and find game tokens. Game tokens are keywords or phrases used in the token hunt game for a chance to win a prize in the daily drawings. Now, let me turn the stage over to Norm Thurston, NAHDO's Executive Director. Norm, the stage is yours.
Thank you, Erica. Welcome, everyone, to our 39th Annual Conference. It's great to see so many people here. I'm Norm Thurston, NAHDO's Executive Director. First, I'd like to thank all of our sponsors for supporting us and making this event possible. We'd encourage you to please take time to visit their booths and learn more about them. We would also like to give a special shout out to NAHDO's strategic partners. These organizations work closely with the NAHDO team to drive high value in all of our work. Since last year's conference, we have 6 new members, and we're pleased to recognize them today. If you or someone you know would be interested in becoming a NAHDO member, please drop us a note. I would also like to recognize the NAHDO Board of Directors, who are literally the world's best volunteers. Thank you all for everything you do to make NAHDO such a great organization. Our program planning committee put in a ton of work to make this event happen. Hopefully you can see their fingerprints all over this conference, and maybe even some of their faces. I do have a few pro tips for first-time platform users. This platform has a lot of features designed to help you experience the full impact of a virtual conference. You can use the conference program and agenda to find sessions that are interesting to you. Inside those sessions, you can actively participate through the chat and Q&A opportunities. Of course, the token hunt is a fun way to engage in the full conference and win prizes. There are also opportunities for you to engage and network. Each day we will host networking sessions, which are opportunities for you to meet in small groups and talk about the things that are interesting to you. Those rooms are capacity constrained, but they will allow you to use your camera and mic to engage with each other. We hope you will take time to join at least one networking session at some point during the conference. Also, please visit our sponsor booths to learn more about them. You can also find people and connect with them directly using the attendee list. And of course, there is the wall. We hope everyone will take just a moment during each day to leave a thought or impression on the wall for others to see. We are so excited. Next spring, will be our 5th annual meeting in Austin, Texas. We hope that you will plan now to join us May 6th through 8th for the in-person meeting and networking sessions. But just like last year, this event will be capacity controlled. So you'll want to pre-register now to reserve your spot. Learn more at nahdo.org/conference. It is now my privilege to announce the recipients of the NAHDO Rising Star Awards. These awards were presented at our in-person meeting in New Orleans to Ertug Misserly and Jillian Ryder. You can read their full citations on our website, nahdo.org/awards. Let's now hear a little bit from both of them.
Hi, everyone. Thank you so much to NAHDO for considering me for this award. It's such an honor, and I feel so grateful. As the Reporting and Analytics Manager at Virginia Health Information, the organization that administers the APCD in Virginia, I can truly say from experience how wonderful it is to be a member of NAHDO and see all the work that they're doing for APCDs across the country. I've really enjoyed my time working with NAHDO and collaborating with its members over these past few years. There is so much opportunity ahead for NAHDO to continue doing the great work it's doing, both for APCDs as well as the other facets of their work. I'm really looking forward to continuing to grow and learn within this community and be a part of all that's to come. Thank you so much again for this incredible honor.
Hello, everyone. My name is Artur Musili. I am the Research Data Specialist within California Department of Healthcare Access and Information. I am mainly responsible for conducting data quality analysis of California's healthcare payments data, as known as HPD. First of all, I would like to thank NAHDO for this award. I'm very honored and I'm very grateful. I would also like to thank to my management team for their support. My fellow ACHI researchers are consultants and on point for their guidance along the way. This award is not just about me, but it represents a teamwork that we share within the department, and it's a reminder of the passion that we all have to improve the data quality of California's healthcare payments data. I am very inspired to keep pushing forward and work on data quality improvement efforts of California's healthcare payments data. And once again, NAHDO, thank you so much for this award. It's an honor, and also giving me an opportunity today to share my speech with you all. Thank you.
Congratulations, Jillian and Ertug. At this time, I'd like to introduce NAHDO's board chair, Kenley Money, for a few opening remarks. And after her remarks, Kenley will introduce our keynote speaker. Let's bring Kenley to the stage, Charles.
Thank you, Norm. Good morning, everyone. My name is Kenley Money, Executive Chair of the NAHDO Board of Directors. I'm with the Arkansas Center for Health Improvement and serve as the Director of the Arkansas All-Payer Claims Database. That's part of the larger Arkansas Healthcare Transparency Initiative. Welcome to NAHDO's 39th annual conference, Telling the Story, Strategies for Improving Healthcare Data. NAHDO is a national nonprofit membership and education association dedicated to improving healthcare data collection and use. NAHDO began in 1986 and cut its teeth working with states to implement inpatient, ambulatory surgery, and emergency department data reporting programs. It did that for many years. Recently, well, not so recently anymore. In 2007, the Regional All-Payer Healthcare Information Council, RAPHIC, R-A-P-H-I-C, began as a convening organization to bring together several northeastern states that had or were developing APCD systems, and so it began. Soon, it was clear that the need was greater than that, and in 2010, the APCD Council was born. The APCD Council is a learning collaborative of government, private, nonprofit, and academic organizations focused on improving the development and deployment of state-based APCDs. The partnership between APCD Council and NAHDO began. It provides subject matter expertise and technical assistance to states and their APCDs and other health data systems. So NAHDO and the APCD Council work collaboratively, providing a unique blend of health data expertise to help states address their common issues, the containment of healthcare costs, and the improvement of health system performance. A short sentence describing very large needs. Together, they are an invaluable resource helping states with health data solutions. If you have not used the APCD Council and NAHDO, please do so. They are well worth it. Not resting on their laurels, NAHDO and the APCD Council continue to execute and manage useful initiatives, such as the Data Quality Forum, that's a few years old, set up to investigate data quality inquiries collaboratively to understand challenges and make recommendations for data quality improvement. The Common Data Layout, which most all of us have heard about, which is a powerful tool for states beginning their APCD journey to reduce implementation time. It makes it easier on the state and the carriers submitting their data. The Non-Claims Payment, or NCP, data layout used to collect data not captured in claims. And new this year, the Hospital Quality Initiative, intended to add value to NAHDO members operating hospital discharge data programs. Over the next 3 days, you'll have an opportunity to hear what health data experts all over the country are doing, and I hope that you have chosen your sessions wisely. With that teaser, let's begin. So, all right, Norm, oh, excuse me, everybody. I am going to do an introduction. Stand by. Just want to make certain I'm in the right place. Okay. Sorry about that. It is with great pleasure that I introduce this year's keynote speaker, Dr. Gloria Sachdev. Dr. Sachdev serves as president and CEO of the Employers Forum of Indiana and also serves as adjunct associate professor at Purdue College of Pharmacy. Her forum initiatives focus on hospital price and quality transparency, value-based health benefit and payment strategies, and health policy. She serves as a member of the Board of Governors for the National Alliance of Healthcare Purchaser Coalitions and as Board of Vice Chair for Hoosiers and Affordable Healthcare. Dr. Sachdev received her BS and Doctor of Pharmacy degrees from the University of Oklahoma and completed a primary residency at the VA in Madison, Wisconsin. Thereafter, she practiced in primary care physician offices managing patients with chronic diseases for 12 years, followed by consulting in the space of incorporating clinical pharmacists into team-based care for 6 years. She retired from Purdue College of Pharmacy after 15 years, but still teaches a few classes for fun, as we all should. She enjoys traveling, taking her dog on long walks, and playing board games with her 3 kids when they are home from college. Thank you so much, Dr. Sachdev.
Thank you, Norm, for the opportunity to present to your group today. My name is Gloria Sachdev, and I'm President and CEO of the Employers Forum of Indiana. Today, I'm going to talk to you a little bit about how employers are using data in an evidence-based manner to inform market and policy decisions. So let me just pull up my slide deck here. Okay. A little bit about the Employers Forum of Indiana. We are a nonprofit that was founded in 2001. We are employer-led, so our board and our executive committee are comprised of self-funded employers who are not part of the insurance or provider industry, and our aim is to align payment with the value of services provided. The problem I'm going to talk to you about today is really that employers and worker healthcare prices are out of control. The way we've been addressing them at the forum is really to start with price transparency and focusing on trying to increase competition in the marketplace. So I'm just going to show a couple of high-level data slides here. This is looking at U.S. employees and employers and how much they're paying for health insurance premiums for a family. So this is family coverage from 1999 to 2024. The dark blue represents what employers are paying, and the dark green represents what employees are contributing out of their paychecks. So oftentimes you can imagine these are like monthly paychecks. And what you can see is the width of each of the bars is getting bigger and bigger, meaning employers are paying more and more every year. And in 2000, total insurance was $6,000, and now it's over $25,000. And again, this is for family premiums. So $25,000 to pay for insurance coming out of your paycheck. But this does not include deductibles and co-insurance. So many of us, including myself, are on a high deductible health plan. So in addition to paying a lot for insurance, I have, several $1,000s that I have to pay before my insurance even kicks in. And then there's like a max out of pocket as well. And for many Americans, that's well over $5,000, oftentimes in the $10,000 to $15,000 range. So how can anyone afford this? Employers, the cost of healthcare is going up for them and for employees as well. We have really hit a wall. We've been talking about we're going to hit a wall, but we have officially hit the wall. When we see what is driving up prices, we see, if you look at the healthcare cost pie, that it is hospital prices. And this is just illustrative of various goods and services and how much their prices have increased from 2000 to 2024. And what you see is that top line there is hospital services have increased 256% over that 24-year period, followed by college tuition below. And things in red have been increasing over time. Things in blue, the prices have been coming down over time. And these are where you really have a free market. Clothing, cell phones, TVs, cars, not in the hospital services market. And why? Why is that? It's because we're operating in the dark. We don't have price transparency, and we have to have options. Those are the two things that drive a free market. The impact of having high healthcare prices, is significant to both employers and employees. From the employer perspective, they have less money to expand and invest in their own businesses if they're paying more for healthcare. So healthcare expenses for most employers is their number 2 line item expense after salaries. There are some industries, such as manufacturing, where it may be their number 3 if they're purchasing more for steel, for example. But it's everyone's number 2 or 3 most expensive line item expenses. So it impacts their businesses from being able to expand. It also is, when they're spending more money on healthcare, they have less money to spend on hiring the best talent, offering robust wages, offering better salaries. Also, they've been cutting benefits over time. They've been cutting healthcare benefits, but also other benefits such as dental, vision, and spousal coverage. Higher premium increases and co-insurances are harmful both to employers and employees, as we mentioned. But for employees, it just means having less money in your pocket to pay for other aspects of your life. High expenses and high prices also lead to more people going into medical debt. There have been numerous articles about patients going into medical debt, and KFF puts that number at 100 million Americans in medical debt. Not all of them are in collections, but a large portion of them are in collections. When folks are in collections, it ruins their credit score. It makes it challenging or impossible for them to get a home loan or a car loan, and thus it can create generational harm. So hospital prices, healthcare prices need to be addressed. We started in 2017 by just wanting to understand, what are the prices? How high are the prices? Where is the variability in prices? Or is there variability in prices? So this was the first of its kind of study in the country that was published. We reported prices as a percent of Medicare and as standardized prices. It was conceived and commissioned by the Employers Forum of Indiana, and we contracted with Rand Corporation to conduct an independent analysis. It was funded by employers and grants from the Robert Wood Johnson Foundation, and no funding was accepted from insurers or hospitals. So we've done a series of studies here, and for brevity, the economists have really long titles, and I call them Rand 1.0, 2.0, 3, 4, and 5.0. So the latest study was published in May of 2024. We started off with 120 hospitals. We now have over 4,000 hospitals that are in the RAND study. It covers 49 states and about $77 billion in healthcare spend. We'll say RAND 5.1 will be launched soon, and I'll be presenting some of those results to you today. So here we have prices, and we're showing prices. We can show prices in multiple ways, specifically in 9 different ways. But this is an illustration of total hospital commercial prices as a percent of Medicare. And when I say total, I mean total inpatient facility, outpatient facility. That's what the hospital gets. And inpatient, outpatient professional, which is what the physician gets. In Indiana, since I'm in Indiana, we are ranked 9th highest, and we're paying 300% of Medicare. That means if you take all of our hospitals that are in this study, about 120 hospitals, and you look at their median price, we're paying 300% of Medicare that Medicare would pay for the exact same services at the exact same hospitals. This was calculated by gathering claims data, paid claims data, and then determining what Medicare would pay for those specific claims using a DRG grouper. Interestingly, when we look at total professional fees, this is just what we pay our physicians. We're 6th lowest in the country, paying them only 127% of Medicare. But you can see there's wide variability with Wisconsin paying the highest at, well over 400% of Medicare. So it's important to understand when we say prices are high, where are they high? Is it on the facility side, on the professional side? And then even within these, you can break it down further. So we have some price transparency, we have some quality transparency, and what are we doing with the information? So I'm going to share some market solutions and policy solutions with you. What's driving a lot of interest in this space right now is that some employees are suing their employers for not meeting their fiduciary responsibility to use health plan dollars in a prudent manner. What that means is that employers have a fiduciary responsibility to employees, since they're taking money out of their paychecks and developing a benefit plan design, that they look at the data and they make evidence-based decisions. They're not sending them to a super high-priced, low-quality organization. Just they need to identify where are the high-value services. So Johnson & Johnson and Wells Fargo, there are lawsuits ongoing right now by employees suing their employer, and there are many, many others underway. So how are our employers using this data? Many of them are direct contracting with providers, bypassing the insurance companies, not for all their services, maybe for select services, such as orthopedics, such as cardiology, etc. They're also looking at bundled payments and centers of excellence. Many of them are putting on-site or near-site clinics, narrow networks and tiered networks. They don't want everybody to be in the same pool. We really are interested in saying, okay, where's the best quality at the best price? Let's put that into, our top tier network, if you will. The things that are middle price, middle quality would be in a middle benefit plan, and then poor quality and high price would be the lowest. So potentially you could say, hey, if you go to the highest value, there's zero out of pocket for you. And then if you decide one of the second layer or third layer, you would pay more out of pocket for that. The key is really making sure employers and all of their partners are making data-informed decisions and putting in performance guarantees into their contracts with their TPAs and PBMs. Looking at legislative policy solutions. Oops, it's like a slide skip there. So I would just want to begin by saying it takes a team to get any policy across the finish line. This is the one in the middle there is me stuck in an elevator with a couple of lobbyists that we work with, and really without them, it's very challenging to educate 150 legislators about any particular topic. But our legislative leadership has really taken the bull by the horns in trying to make healthcare more affordable for employers and employees. This bottom middle picture is my team, and I mean, nothing happens without them. So I'm so appreciative. What have we done? So we got involved in policy in 2020. Excuse me, we got involved in policy in 2020. And I'm just going to share with you what we got across the finish line in 2023 and 2024. And this is at the Indiana state level, if you will. So what we got passed into law. In 2023, we set a price benchmark of 285% of Medicare, against which our five largest hospital systems will be compared. That report will be coming out before year's end. We eliminated hospital facility fees. We could see hospitals, some of our largest hospital systems are buying up all these independent physician groups, physical therapy groups all over town, all over cities, in strip malls. And then they're tacking on a hospital facility fee just so the price goes up, the total price goes up, even though it's not anywhere near a hospital. So this says if you're off campus, you're not allowed to charge a hospital facility fee for any of these labs, imaging, physician office visits, etc. Another one we passed was in Senate Rule Act 7, and that bans physician non-competes for primary care providers and then for all providers as their contracts renew over time, their new or renewed contracts. This past session ended in April, and actually in March. It ended in March, and we were in 3 months able to get a few things across the finish line that are very meaningful. And in the data space, we were able to establish that employers own their own data. Just because you partner with a PBM or an insurance company doesn't mean that these middlemen own the employer's data. The employers who are self-funded are paying for all of the data, all of the claims, as we saw in partnership with their employees, as we discussed. So they should be able to look at their own data, and it's been a huge challenge up until now. So here we have that employers own their own data and they can audit it. They can do deep dive audits. There can't be outrageous fees for it. And then we also we're looking at mergers and acquisitions. The mergers and acquisitions now have to go to the Attorney General's office, and they're monitoring for antitrust activity. One tool that I did want to share with you is Sage Transparency. It's a freely, publicly available online tool that we launched in May of this year. And it has hospital price, quality, and some financial data that's available. Sage Transparency simply brings together 5 different data sources. And for folks now, this is probably the wrong audience because you love data and love Excel spreadsheets, but many folks don't, and they want to be able to navigate the information easily so that it's usable for them. So that's what Sage Transparency is. It really is the easy button, is what I've been told. So we have 3 public sources of data. We have the RAND data, which I mentioned. NASHB is the National Academy for State Health Policy. They developed an amazing hospital cost tool that has hospital financial data over a 12-year period. So we just pulled a few of their data points for the latest year. CMS has Hospital Compare. So they have hospital star ratings, patient experience, and HRRP is the Hospital Readmission Reduction Program. So we pull these 3 data sets into Sage Transparency. We have a couple of proprietary sources as well. One is January Advisors. We have a lot of policymakers that are interested in knowing how are their hospitals and their district comparing to the largest hospital systems in the state, comparing to the state average, comparing to the national average. And so we partnered with January Advisors to basically have a polygon analysis of legislator districts in every state. So at the state level for state legislators and at the federal. And I can go on Sage Transparency and tap on the legislator tab and see that information. Quantros is owned by Healthcare Blue Book, and they provide some quality ratings. So we included some of those, a subset as well. Here is sagetransparency.org, just a screenshot of it. And what you can see is there are 9 tabs across the top. The first one is hospitals. It defaults to Indiana, but you can pick any state. We have 49 states plus DC. We exclude Maryland on purpose because they pay their hospitals in a unique way where everyone's paying the same. Hospital system tab, hospitals by state. You can look up clinical categories if you're interested in seeing an MRI or colonoscopy, or I should say GI procedures. You can search in your area or in your region to compare prices. State compare is something legislators oftentimes look at. They want to see how they're comparing to neighboring states. We added ambulatory surgery centers, medications, and then here's the legislator tab. The last tab's the glossary tab, and it just has a bunch of definitions and links to all the resources. A couple of screenshots just to give you a flavor of what you might see on Sage Transparency. It's very interactive, easy to use. It is built on Amazon QuickSight. Many of you may be familiar with that tool, and we partnered with Quantify. We partnered with Quantify as our vendor they've been great to work with and partner with us as we try to bring this vision to life. Just as a sidebar, data is so important, not just on Sage Transparency, not just the hospital cost tool, but states, including Indiana, have developed an all-payer claims database, or an APCD. Over half the states in the United States have APCDs. Ours was just launched on August 5th of this year. We're really excited about it. We passed the law in 2020. So it's 4 years in the making. And if this is something that would be of interest to you, I've included the link there. But it is pretty amazing because you can pick a procedure, where ours on Sage Transparency's clinical category, so higher level. This is at the procedure level. You can pick your plan, such as Anthem PPO plan or United Healthcare PPO plan, put your zip code in, and then put how far you're willing to drive, and it will show you what your options are. So that's the end of my presentation. Thank you so much, and I'm happy to answer any questions.
Thank you so much, Dr. Sachdev. My apologies. There were too many questions as I went through to ask. Just terrific. Well, first of all, just a little home stuff. How did you get into this? How did you begin participating in this endeavor?
It's a great question. And first of all, thank you for having me. Excuse me. Thank you for having me. It's just a real honor for me to be here with you today, virtually. We got involved with this because the employers, when I took this job 9 years ago and I met with our employers, they all said healthcare costs are unaffordable. And many of them had a footprint here in Indiana, but also across the country. And they were able to see at a very high level that their claims data, from their claims data, that the prices that they were paying in Indiana were higher, but they weren't able to see it at the provider level. And so we thought that would be a really good place to start. They know that their costs are high, and there's 30 years worth of literature to focus on utilization, but cost is just price times utilization. And so while the industry's been focusing on decreasing emergency room visits and so on and so forth, not as much attention was being spent on the price side. And there have been some economists in the past that, including Uwe Reinhardt, the late great Uwe Reinhardt, who said, it's the price is stupid. That was the name of his article. And so we a couple of decades later are now have that information at our fingertips. So we just wanted to understand, are our prices high? And then how high are they?
We have our first question. I'm going to go to that before I go to my inventory.
Okay.
Mark asks, did you develop the cost transparency website internally or partner with a vendor?
We developed Sage Transparency. We developed it conceptually. We put out an RFP, and we contracted with Quantify as the vendor that built it for us, and we were on daily calls with them. So we got Sage Transparency built in less than 6 months, but it took an effort from our team working closely with their team to execute on it. And I should say we update Sage Transparency quarterly. So we'll see an update here. Now that elections happen, we'll update that in February, so on and so forth. So as CMS updates their data quarterly, so does Quantros and other data sets, we will just keep up with it.
Mm-hmm. Mm-hmm. The screenshots, it looks really great. So, so I noticed on the slide where you were talking about the legislation that was passed, and there was a piece about the hospital facility fee was removed from the facilities, not at the hospital. Have you seen or that the consumer is having to pay elsewhere to make up for that? Is there a risk of that?
So actually what happens is when a hospital, when they go on a consolidation spree, if you will, they go into the community and then they buy up all these independent physician office clinics. And then they tack on a hospital fee, so the overall price for the service for the patient would go up. That law, while we passed it last year in 2023, doesn't go into effect until January 1st of 2025. So it's an excellent question, and we'll have to go back through our claims data to see if the 5 largest hospital systems are being compliant. And they were tagged because they made more than $2 billion in revenue. And that's what the statute says. So it's in House Enrolled Act 1004 from last year, in case anyone's interested in looking at that language.
That would be very, very interesting. Periodically over the couple of years, because I run the Arkansas APCD, I will get a call from an impassioned small employer about needing visibility, and the getting into the data for someone like that is different, and so we don't have a great solution. But that you described the problem exactly. They don't have visibility into their data. They pay TPAs and PBMs to do all this work. And we know from experience that if an employer wants it changed, their PBM and TPA will charge for it, and it is cost prohibitive. Do you have any advice that I can give small employers to that end, or have you seen a solution that might work to help them?
So it's a problem, right? So they charge to give you access to their own data, which we prohibited by law. Just this year, we're like, it's their data, number one. They get to audit it, and they get to do deep dive audits, including getting the 835 and 837 electronic file claims transactions. And you can't charge them for one audit annually, or access to their own data. However, I think what you're talking about, sometimes they will say, oh, if you want us as a TPA and you want to not use our PBM, you have to pay us a fee, a carve-out fee. And I cannot stand that. I mean, you are charging me to provide, you're charging me to not provide a service, right? You're going to charge me and not provide me a service. That's just crazy to me. And they will continue to do that. Employers need to stand strong and just look at those contracts and start striking them out. It can be hard because there's so much consolidation in the TPA and PBM space. There are these behemoths, and there may not be, maybe 1 or 2, 3 options in your area, and you're kind of just stuck with these contracts. Should that be the case, you have to get involved with the legislative policy aspect, because it's only through policy that they could put in statute and say, you're not allowed to charge them for a carve-out fee, which is, as I said, ridiculous. There are business coalitions like ours. We're the Employers Forum of Indiana, but there are coalitions throughout the whole country. Employers, if they come together with a unified voice like we have, are able to more successfully get things across the finish line, both in the marketplace by talking to all of these stakeholders, and in the from a policy perspective, than if they try to work on it, no matter how big they are, if they try to work on it individually.
Yeah, thank you so much. Well, I want to conclude by, is there anything that you've told us so much? Is there anything you want us to close out with?
And I really appreciate all the work that everyone's doing in the data space. We still have a long way to go. I feel we can see it though, I can see it. So I really appreciate everyone working in this space. I'm just a user of the data. I don't put it all together and do all the really hard work. So just very much appreciate everyone in the audience today that's in this space. And if I can be of any assistance to you, please don't hesitate to reach out.
Great, thank you. I want to give a shout out to the Indiana APCD. My team was on a call with them last week or the week before, and they're great. So,
well,
thank you very much. We're about to close out and move to our plenary session at 10 minutes after the hour. Thank you so much.
Thank you.
Charles will take us away.